Okay, now I'd like to introduce the last speaker, Professor Leona Poon. She is so well known, so I'd like to introduce her briefly. She is an academic subspecialty in maternal fetal medicine, devoted in improving maternal and fetal health. In the last 10 years, she has focused her research on establishing a program for effective early prediction and prevention of preeclampsia, a major cause of the maternal and perinatal morbidity and mortality. With the success in developing a first trimester prediction model for preeclampsia using maternal risk factors, ultrasound, blood pressures, and biochemical markers, and an aspirin prophylaxis against preeclampsia. Her goal in the next 10 years is to improve obstetric care worldwide through clinical research and education. Actually, she is passionately engaged as the Isuog leader for the Asian region. So I'm deeply grateful for her efforts toward successful Seoul Congress in this year. So today she will give us a screening for preeclampsia, what's new and what's next. Please.
Good day to all of you. Thank you for this opportunity to give this talk on screening for preeclampsia, what's new and what's next. Here are my disclosures. Professional organizations have recognized the importance of early identification of women at high risk of preeclampsia in the hope to improve pregnancy outcomes. However, despite our effort, as you can see, maternal mortality has only improved slightly since the early 90s. Not only is preeclampsia an immediate risk to the mother during pregnancy, there's strong evidence that for those who develop preeclampsia, they're more likely to suffer from hypertension, ischemic heart disease, thromboembolism, and cancer later on in life. What's more is that the risk of death is more than doubled for those who have suffered from preeclampsia than those who haven't. And this risk is particularly pronounced for women with early onset preeclampsia, which is considered the more severe form of the disorder. Further, it is early preeclampsia that is associated with high risk of perinatal morbidity and mortality. So the earlier the delivery for preeclampsia, the higher the risk of fetal growth restriction and perinatal death. All in all, when we develop strategies for the screening and prevention of this disorder, the outcome of interest should be early preeclampsia. In relation to screening of preeclampsia, we now advocate for the use of the competing risk approach to combine maternal risk factors to determine the prior risk, and then use Bayes' theorem approach to modify the posteriori risk with the addition of a number of biomarkers, which are expressed as multiples of medians following correction for certain maternal factors that influence these biomarkers and gestational age at screening. This approach can provide individualized patient-specific risk, and specifically, this approach can also account for the relationship between the biomarkers as well as the severity of the disorder. Using this combined approach, we are able to achieve excellent detection for early onset preeclampsia with a detection rate of 90% at a 10% false positive rate. As for preterm preeclampsia, the detection rate is slightly lower at 75%, and for term preeclampsia, the detection rate is at 45%. In clinical medicine, number needed to screen is a tool for measuring screening benefit. According to the aspirate data, the number needed to screen to prevent one case of all preterm and early onset preeclampsia, 143, 250, and 400 respectively. The number needed to screen for preventing one case of preterm preeclampsia is equivalent to the number needed to screen for the prevention of one case of early infection due to GBS through universal screening at 35 to 37 weeks of gestation. Compared to screening tools in clinical oncology, this number is far lower than the number needed to screen for the prevention of one case of breast cancer, with mammography, lung cancer with CT imaging, colon cancer with colonoscopy, prostate cancer with PSA, and cervical cancer with either pap smear or HPV testing. Here, I would like to recap that in our combined test, we've added 3 biomarkers. One is mean arterial pressure, second is uterine artery pulsatility index, and third, placental growth factor. Here is the protocol for the measurement of mean arterial pressure. Our tip is that for the measurement of blood pressure, it is best to measure in both arms simultaneously, so it is not time-consuming. You can scan this QR code here for more detailed description. It is very important to comply with this well-established protocol for the measurement of blood pressure in order to maintain good screening performance. The second biomarker is the uterine artery pulsatility index. And here is the protocol for the measurement of this ultrasound marker. In the first trimester, we recommend that we measure uterine artery pulsatility index via transabdominal ultrasound. The way to identify the uterine arteries is to firstly apply the transducer longitudinally over the suprapubic area to obtain a sagittal section of the cervix, and then use color Doppler, gently tilting the transducer to the side to identify the uterine arteries at the level of the internal cervical os, as you can see in the top picture. Using a sampling gate of 2 millimeters to cover the whole vessel, and ensuring the angle of inclination of less than 30 degrees, you obtain the waveforms as seen in the bottom picture. It is important to check that you have indeed sampled the uterine arteries. So to check, you need to make sure the peak systolic velocity is more than 60 centimeters per second. You measure both left and right uterine arteries, then take an average of the two for the risk calculation. The key to easy measurement is to know the anatomy, and fixing the transducer in the midline and gently tilting the transducer to the side of the cervix slowly would allow you to see the uterine artery at the level of the internal os easily. As for the Doppler settings, the pulse repetition frequency, PRF, of color Doppler is usually maintained between 3 and 4 kilohertz. The scanning speed should be adjusted so that there are 4 to 10 waveforms on the screen. The PRF is adjusted so that the size of the waveform occupies 50 to 75% of the scale, and a low-pass filter is used. Now, quickly moving on to prevention. And I know almost all of you are familiar with the ASPRE trial. And within that trial, we utilized our first trimester combined test to identify high-risk women. And high-risk women were randomized into receiving either aspirin 150 milligrams nightly or placebo from 11 to 14 plus 6 weeks of gestation till 36 weeks. And then through that trial, as you can see in the graph on the left, we were able to demonstrate a significant reduction of the rate of preterm preeclampsia by 62%. And what's more, we were able to achieve 82% reduction for preventing early onset preeclampsia. With regard to number needed to treat, on the right, you can see from the table that to prevent 1 case of preterm preeclampsia, we have to treat 38 high-risk cases. And this number increases to 69 when our focus is on early preeclampsia. As for preventing small babies, the numbers needed to treat range from 16 to 30. And for preventing perinatal death, the number needed to treat is 34. Through these 2 slides, I've demonstrated that we indeed have an effective model for early prediction, and we have an effective method for early prevention. Though I'm happy that through our first trimester screen and prevent strategy, we can achieve good results for preventing preterm preeclampsia, there is still a high proportion of high-risk women who is not benefiting from aspirin prophylaxis. That has led to a very important question: who do not respond to aspirin? I think it is very important that we try to understand why some aspirin-treated high-risk women develop preterm preeclampsia eventually. Firstly, we have found a significant interaction between aspirin usage and history of chronic hypertension in the prediction of preterm preeclampsia, which indicates that there is no treatment effect in high-risk women who have chronic hypertension compared to those who do not. Adjusting for aspirin usage and the interaction between aspirin and chronic hypertension, independent predictors for the development of preterm preeclampsia a low PLGF mum, less than 0.712, and very high estimated risk. Women with risks of 1 in 2 to 1 in 10 have a 6-fold higher risk of developing preterm preeclampsia, and women with risks of 1 in 11 to 1 in 50 have a 2-fold higher risk of preterm preeclampsia compared to those with risks of 1 in 51 to 1 in 100. Our results have shed some light on who we need to follow up more closely during pregnancy despite aspirin prophylaxis. And these high-risk women should be informed of the potential risk of developing preeclampsia despite aspirin use, and that they are offered more frequent monitoring of blood pressure. Next, I undertook a study with the use of pharmacometabolomics analysis to understand why high-risk women go on to develop preeclampsia despite aspirin prophylaxis, and we found some interesting important findings. There were several steps to our analysis. First, we compared metabolomics profiles in aspirin and placebo second trimester samples using multivariate analysis, and reassuringly, the model showed complete separation of placebo subjects and aspirin-treated subjects. This figure is a heat map of the 54 aspirin-altered metabolites identified in multivariate analysis. The list includes the immediate aspirin metabolites, salicylate and salicylurate, as upregulated upon aspirin treatment, as shown in red. We observed an overall decrease of metabolites in histidine metabolism, glutamate metabolism, long-chain polyunsaturated fatty acids, as shown in green. Next, we evaluated the association between internal exposure of aspirin and clinical response to aspirin treatment. In the ASPIRATE trial, participants self-reported compliance, and we used this to plot against internal exposure that was determined metabolomics analysis and estimated as leaf-to-out orthogonal projections to latent structures discriminant analysis. Samples are colored differently by pregnancy outcomes and treatment group. Orange as aspirin-treated non-preeclamptic, green as aspirin-treated preeclamptic, blue as placebo-treated non-preeclamptic, and purple as placebo-treated preeclamptic. As you can be reassured that the aspirin and placebo groups are completely separated. We then evaluated the distribution of reported compliance and internal exposure in aspirin-treated women with and without preeclampsia. You can see that internal exposure was significantly different between preeclamptic women and non-preeclamptic women with aspirin-treated group. Then we evaluated the impact of aspirin treatment on the metabolic clock of gestation. First, we built a multivariate metabolic clock of gestation using the metabolomics profiling of the pre-treatment and placebo-treated samples. Second, we used the clock to predict the gestational age in the aspirin-treated group. Aspirin-treated samples were estimated to have a younger gestational age than placebo-treated samples, depicted by the left shift of the green peak from the blue peak. In the aspirin-treated group, gestational age acceleration significantly deviated from zero in a negative direction by 1.27 weeks, as shown in the green box, suggesting that aspirin significantly delayed metabolic gestation. We also demonstrated that aspirin partially reversed 1/4 of the metabolites changed over gestational age advancement. All in all, our findings suggest aspirin treatment slows down the metabolic clock of gestation. In our clinical practice, we've now moved away from explaining to our high-risk women that aspirin eliminates the risk of early preterm preeclampsia. We tell them that aspirin can potentially reduce the risk of preterm preeclampsia by slowing down placental aging. And therefore, high-risk women should remain vigilant about any signs and symptoms of preeclampsia. Many of you have asked if our algorithm works elsewhere, and I can confidently tell you that yes, of course. And here are the results on screening performance in a total screen population of 10,000 Asian women, and fixing the false positive rates at 10 and 20%. The detection rates for preterm preeclampsia in both our population and the FMF population are very similar, as you can see in this diagram in the middle. And most importantly, when we have looked at comparing the screening performance of our model in Asia and that of NICE and ACOG approaches, it is very clear that the FMF triple test is superior to the checklist-based approach as recommended by ACOG and NICE for the prediction of preterm preeclampsia. Here I reference the results from the SPREE study, highlighting the importance that the addition of biomarkers to maternal factors can double the detection rate for the prediction of early onset and preterm preeclampsia and even term preeclampsia. But I'm still very keen to see if we can further improve the screening performance with the addition of novel biomarkers. But let's take a step back, and I know many of you are curious about to see whether PAPA has any role in the prediction of preterm preeclampsia, given that PAPA is routinely available through the screening of Down syndrome. We've done a head-to-head comparison with these three combined tests. The blue bar represents the triple test with PLGF, and the red bar represents the quadruple test with the addition of PAPA. The green bar represents the triple test with PAPA instead of PLGF. So you can see that the addition of PAPA contributes minimally to improving the area under the curve as shown. And as for comparing the triple test with PLGF against the triple test with PAPA, here because of the sample size, I'm unable to demonstrate a statistical difference. But then if we look at the impact on individual cases, in this cohort of more than 5,000 women screened, there were 37 women developing preterm preeclampsia. And when we use the triple test with PAPA, the detection rate is about 51% at a 10% false positive rate. But when we swap PAPA with PLGF, we can improve the detection rate to nearly 60%. If we have replaced PLGF with PAPA, then 3 high-risk women would have been missed. And certainly, this would have an impact on individual basis. So our search for potential biomarkers continues. And I want to highlight these 3. One is a placental marker, one is a cardiac marker, and one is a marker of vascular endothelial injury. We've chosen these markers because of the underlying pathogenesis of preeclampsia. Inhibin A and anti-pro-BNP are biomarkers that are currently used in the clinical setting, and glycosylated fibronectin has also been introduced as a point-of-care test as a short-term predictor and aid the diagnosis of preeclampsia. These 3 biomarkers are readily available to implement in the clinical setting if they could improve preeclampsia screening performance. So I just want to briefly share with you our results on Inhibin A. As for anti-pro-BNP and glycosylated fibronectin, I hope I can share with you the results in future presentations. What I'm showing here are the results according to the 2 different types of preeclampsia. Because in many parts of Asia, the provision of uterine artery pulsatility index measurement may not be readily available. There's a desire for us to consider finding an alternative biomarker to uterine artery pulsatility index. And hence, we've done this analysis. With the use of the triple test based on PLGF, as you can see, for the prediction of preterm preeclampsia, the area under the curve is 0.859, and we've replaced uterine pulsatility index with Inhibin A. We are able to match the area under the curve as per the standard triple test. And this is also the case for the prediction of term preeclampsia. In terms of implementing early screening for preeclampsia in Asia, I think this is something we have to consider if we are able to provide combined screening with measurement of blood pressure and a number of biochemical markers. It may be a more pragmatic approach, but nonetheless, we need to remember that in order to convert these biomarkers into multiples of the median, a first trimester scan 11 to 13 weeks is still essential for the measurement of fetal chromosome length. Liquid biopsies that measure circulating cell-free RNA offer an opportunity to study the development of pregnancy-related complications in a non-invasive manner and to bridge gaps in clinical care. In the recent years, we've seen a very exciting study demonstrating that early prediction of preeclampsia in pregnancy with cell-free RNA is achievable. And this study has identified and independently validated a panel of 18 genes that were measured between 5 and 16 weeks of gestation. But I do want to draw your attention to the fact that the study utilized 4 different case control cohorts, and only in the discovery cohort that the area under the curve was 0.99, whereas for the other 3, validation 1, validation 2, and Del Vecchio, only achieved area under the curve between 0.71 to 0.74. So we raised some questions. With the approach proposed by the study published in Nature, we know that RNA-seq is required, which is expensive, time-consuming, with a long turnaround time. It is certainly not readily scalable to universal screening. Can we convert the cell-free RNA preeclampsia screening test into real-time qPCR format, which is inexpensive with a short turnaround time and potentially scalable to a large-scale screening setting? So we have quickly done our case control study, and out of the 18 genes, we have identified that only 2 are related to the placenta. And contrary to what the Nature study has presented, in our study, we've demonstrated that these 2 cell-free RNA markers are upregulated instead of downregulated. Reassuringly, you can see that the combination of maternal factors with mean arterial pressure and either one of these cell-free RNA markers can achieve very good area under the curve exceeding 0.9. So hopefully we'll be able to validate these results in independent cohorts in the near future. Lastly, I just want to make reference to an ultrasound marker, because obviously this is an ultrasound meeting. The work of the Fetal Medicine Foundation has highlighted the potential clinical utility of the use of ophthalmic artery Doppler in early pregnancy. This study aimed to examine the potential value of this ultrasound biomarker at 11 to 13 weeks, alone and in combination with the established British domestic biomarkers of preeclampsia. Modeling demonstrated that the addition of ophthalmic artery PSV ratio improved the detection rate at a 10% false positive rate of preterm preeclampsia provided by maternal factors alone, from 46.3% to 58.4%. Maternal factors, mean arterial pressure, and neutral artery positivity index from 65.9% to 70.6%. And maternal factors, mean arterial pressure, neutral artery positivity index, and PLGF from 74.6% to 76.7%. So where do we go from here? Our future directions. It is important to consider multi-omics systems biology studies. We need to look into the contribution of placental aging, placental senescence, and mitochondrial dysfunction. In relation to placental biomarkers, I've shown some very exciting results. So placental RNAs, placental proteins are the mainstay. Endothelial and cardiovascular biomarkers, as I mentioned, hopefully I'll be able to share with you our results on NT-proBNP and glycosylated fibronectin. And as for ultrasound markers, I think the results from the Fetal Medicine Foundation are encouraging. And then there are also other groups looking at 3D placental imaging as well as placental elastography. Thank you very much for your attention. I'll be happy to take some questions.